few scenarios to help Sarah kind of practice her effective explanation. So the first scenario, Sarah, so we've got subjective history, walking 2 weeks ago and started to get pain in the front of his right knee. It's gradually got worse and he's getting pain walking up the stairs. His history is he sprained the same ankle 2 months ago and he just recently got back into walking and the pain started. And now he's starting to get frustrated because he's not able to walk and that's the thing he enjoys the most. So objectively, in the generic objective there was no pain, but he was getting tightness when he was rotating to his right with poor ankle movement. Yeah. He had a positive posterior knee stability test, which are those tests that we do on the bed, breaking at the knee, and he was getting pain with knee flexion, passive range of motion. There's no joint effusion or swelling, all of his special tests are clear, and he's getting pain when he's lunging on the right leg. And his goal is to get back walking. So the main recaps is he's getting pain in his right knee, he's got a previous right ankle sprain, and he's got a positive posterior knee stability and a tight quad.
Perfect. Right, so ideally what we're wanting to see is when the foot hits the ground, when it's coming into contact with the floor, all these muscles will be working together. And we're wanting 25% here, 25% there, 25% here, and 25% here.
Nice.
What's actually happening in your case is, we did the squash the orange there where you push down into my hand. These muscles weren't actually working properly, so let's just say for example, we've got 5% here, 5% here, and 5% here. Instead, what's actually happening is these muscles across the front are overcompensating. So you're doing more work here, which is what's causing your knee pain at the front. Now, ideally, what we normally see is in a couple of weeks' time, you'll end up like this. So we'll all be working a little bit better with the rehab, but this issue is still there. So you might not actually have the pain, but the issue is still there. So, do you want me to go through the...
No, I think that's fine. I think that's really, really good. So again, I think what's really important about this point now is that the pain is still there. The pain has gone away, but the problem's still there. So then we ask the question: can you see how we're still not ready to go back walking long distances yet? Yeah. So until we get it to the point where everything's going to do its job and everything is absolutely fine, that's when we can start to walk longer distances. No, so that's really, really good. The next scenario is we've got subjective history. 2 weeks ago started to get some right hip pain getting out of the car, just driven back from London, and he felt fine until he tried to get out of the car. He does have a history of back pain, but tends to manage that okay himself with his exercises. He's got a long history of right knee problems, including 2 surgeries, and the pain has gradually got worse, and now he's starting to get sciatic pain down his leg if he sits for too long. His main goal is he commutes to Manchester 40 minutes a day, and it's hurting a lot, and then he's sore all day at work. So his objective findings were he had poor frontal plane movement in the generic objective, he was getting pain on toe touch in his hip, passively he was getting a pinch with hip flexion, and he had restricted adduction. And then coordinated testing wise, he had a positive posterior knee stability, again breaking at the knee, and positive lateral direction breaking at the hip. Frontal plane.
Right, okay. I don't think my maths is going to be as good on this one.
Yeah, that's fine.
So
that's the hardest part.
Yeah. So I think, did he have any back pain, did you say?
Yeah, a history of back pain, yeah.
Right, so we're going to put the back into it on this one. Sorry, it's a bit complicated.
That's perfect, yeah.
So he had, do you know when you broke at the knee, when we squashed down into my hand, these muscles weren't working properly, so 5%. You're getting your hip pain is where the muscles are compensating.
Or back, what's left?
I don't know.
30%. It's the hard part. That's why it's good to keep the numbers small, but again, 55, 65, 70, 50. I think I'm wrong actually. 55, 65. No, this 75, so it's 25%. So the back's doing 25%.
Perfect. Nice.
Yeah.
Is that alright?
Yeah, that looks good, yeah.
Right, so same again. In a couple of weeks' time, when your pain is gone. Sorry, we've got to. So these will go up to 10.
Yeah.
And then the hip, oh no, that's back.
Yeah, it takes some practice with these ones. So the way I'd probably structure that is I just keep it really, really simple for this. So if we're talking about his back, so if we go foot, knee, well, mine's even worse, foot, knee, hip, and lower back. So if we're talking about, I just say, look, we want the ankle, ideally to do maybe 20%, the knee to do 20%, the hip to do 20%, the lower back to do 20%, and let's say the upper back to do 20%. So everything's got to do its job. For you at the moment, just to keep it really simple, we've got these tissues in your leg with that test that we saw on the bed. So again, give them proof related back to the tests in your assessment. Those tests are positive, so they're not doing the job. So the glutes definitely gonna have to work a little harder. This is working fine at the top. So what have we got there? We've got 20, 30%. So this has probably got to do a little bit too much. So this has probably maybe got to do, let's say, 40%, and then this has got to do 30%. So some of that lower back pain that you get, and then some of that hip pain that you get at the moment, is probably caused from the fact that these aren't doing the job very well. Obviously, with the way I'd kind of frame that for him is with your history of the knee problem you've had on that side with the surgeries, your body's probably trying to protect your knee a little bit. Obviously, you've got a tight back, and then the hip's kind of just stuck in the middle, and then it's getting a little bit sore. And then we're trying to do this, makes it a little bit easier. We can just step these things up to 10%, 10, and then leave that as 20. So we've got 20, 30, 40. So this makes got to do 30, and then that's 40, 50, 60, 70, this is going to do 30 still. Does that make sense? Yeah. So you just kind of breaking it down. So now his hip will be a little bit better, his back's the same as it normally is because it's a long-term problem. Pain will be better at this point, but we're still not there yet. We still have a little bit more work to do until we can be confident it's going to be able to handle it kind of full time. Yeah. But that was really good. So I suppose we're supposed to do a quick kind of recap and reflection on the week really. So I suppose, Sarah, how have you gone this week? How have you found it?
It's been alright, to be honest.
Yeah.
It's been good.
Cool. What do you think the biggest challenge has been?
I don't think it's been challenging as such. I think it's been like a nice, basically like a good warm-up today.
Yeah.
Maybe it's something more heavier.
Oh, nice. Cool. What's your biggest takeaways?
I think the external and internal part of it is, and like building like a relationship with your client as well, rather than just being literally going through like A, B, C, D, like a list, all that kind of thing.
Yeah.
Like, you're actually doing it in conversation rather than it being really clinical.
Building connection,
Yeah.
I think it's really important, that just generally in life as well as in physio, is just actually being able to build connections with people. And I think we're going to get much better results with somebody if we actually know their story, rather than just, like you say, jumping straight into an assessment. And I think sometimes meaning really, really well, as a physio, we can be very rushed in terms of we need to get straight into the treatment straight away and just try and fix the problem, but actually just taking a step back, getting to know the person, getting to know their goals, getting to know what they're aiming for, getting to know what's happened to them before, it's really, really important.
Yeah.
Oh, good. What are you looking forward to most about the next few weeks?
I think the biggest thing in my head is being able to do an assessment properly and confidently.
Yeah.
That's my biggest.
Yeah.
That's what I want to take away from it.
Yeah, just having that confidence whoever walks in the door, you're going to be able to assess it. Yeah, not good. Perfect. Cool. So I suppose the biggest takeaways from my perspective for week one are, like Sarah was saying, the internal and external motivators. I think also building a connection with your patient, and I think understanding the person's story. So what's happened to them in the past, where do they want to go towards, what are the previous stressors maybe that might be contributing to their current pain experience. And if we can understand those things, we set ourselves up for a lot of success then when we go to the objective assessment in module 3. And I think understanding the subjective is just a really good foundation to have before we go into the objective. And I think, like Sarah was saying, it can be easy to rush that sometimes. But I think just taking our time in the first session, understand the story, get a plan, make sure that we have clarity, the patient has clarity. I think that's really, really important. Cool. So in next week's episode, we're going to be going into module 2. So we're going to go through the full assessment for a lower limb, basically. So module 2 is all about sessions 1 to 3. So obviously we've got the initial assessment, which is mainly module 1, which is a subjective assessment. Sessions 1 to 3 then is going to be all about, first of all, finding the root cause of the problem. It's going to be desensitizing the symptoms, and it's going to be starting the path on the road to recovery, basically. And we want to make sure that we first of all know the symptoms, but more importantly, we understand the root cause of the problem that's influenced those symptoms. So module 1, the subject is going to be really, really important for that, but now we need to do our objective assessment, and we need to be able to make sense of the findings and relate it back to the subjective assessment. And that's a real kind of skill I think in terms of therapy. If you can do that, it makes your life really, really easy as a therapist. So that's what we're going to cover next week, so make sure you get tuned for that.